All right, good. All right, let me get back in the, okay. So there's my slide on organization, starting a notebook. Um, so for an example, maybe, on a certain date, you lost your balance, you almost fell. That never happened before, but gee, it was late in the evening, you were really tired. That would be something important to write down for us. Okay. Again, you want to include both motor symptoms and non-motor symptoms. You want to create a folder, at least one, or have a notebook. And well, so again, this is Carol's information. She says have one folder for each physician or medical provider. I would vote more for having a three-ring binder so that you only have one place to go and then have, separators for each physician or medical provider because knowing me, I would pick the wrong folder, okay, to take to the wrong doctor. So have a three-ring binder and then have a list of your physician, the name, the telephone number, the email, or your MyChart account. You might want to put the name of the medical assistant or the executive assistant of the physician so that you know who you need to talk to. And then you can put questions or issues in there that arise so that you don't forget. So then when you go to your doctor's appointment, you just take that with you. And fortunately, many of my patients are doing that, or their spouses or caregivers or care partners or children. They're learning to do this. So let's talk about getting ready for a doctor's appointment. You want to check your notebook and your folder for any of that information that I just talked about. When did you fall? Did you start new medicines? How are things going? You want to prepare your questions and write them down because if you don't do that, believe me, you forget. So, and then you kind of want to prioritize it because I've had people come in, with a list umpteen long, and we're not going to be able to get through that in 40 minutes. It's not possible. So make sure, what are your important questions? You want to have an up-to-date list of medications and include information about any new medical physicians or providers, ED visits, emergency room visits, or falls. And then a list of any surgical procedures or new diagnostic testing or even pending surgeries, whether it's cataracts or an elective surgery, and we'll talk more about that. And is my volume okay? Can you guys hear me?
Yes.
Yeah,
Okay.
yeah.
All right, good. So after the visit, again, you want to write down what went on. Okay, you could put your after visit summary in there. I know Dr. Duker is the best at putting the visit plan. He puts everything in there. I'm not as good. I only put the changes in the patient instructions on the after visit. Um, I'm not sure what the other docs do. I think Dr. Jacob puts the changes as well. But I typically highlight those instructions and I highlight the next physician visit. So, put that in your folder. And not everybody probably has a three-ring, hole puncher. So maybe that's why folders are easier, but I'm telling you, it'd be worth it to invest in the three-ring puncher um, to keep everything in one place. You want to label everything with, again, the provider name and what doctor. Going through my brother's doctor's list, oh dear Lord, he's got a cardiologist, a pulmonologist, his primary, a neurosurgeon, a neurologist. He has essential tremor and has DBS. So, all that information needs to be in one place. It would be best if it was all in one place. Let me say that. MRI reports, any blood work. Of course, now with Epic, most people are on Epic unless it's more of a private company. So like OrthoCincy, if somebody goes to OrthoCincy, I don't have access to that because they're not on an Epic sharing communication. But if you're in a hospital, I have access to almost anything in the hospital. So if you do have an outside, outside of my chart physician, it would be helpful to keep that information or to copy it or ask for a copy of your MRI results or blood work. In terms of important lists and charts, I just realized I minimized all of you who are attending, so I can't. Chris, you're going to have to tell me if they raise their hand with a question, okay? Because I can't see my screen and the people at the same time. Okay, um, lists and charts. So again, a current list of medication. And then, for example, you might want to put why you're taking it. Make sure you have the correct dosage and the strength and how many tablets you take. It'd be great if you put the times. I'm not, I will ask that in my clinic visit almost always. I ask for the times. And then the reason you take it. That's not so much for us as it is for you. So for instance, my brother is on metoprolol, propranolol. I asked him, do you know why you're taking this? No, they just told me to. Okay. Some drugs may have to be refrigerated, or you don't take them after a certain time. For instance, we use selegiline and midodrine a lot. Selegiline is a drug that helps release more levodopa in the brain, and we don't want you to take the second dose after 2 o'clock because it can cause wakefulness and interrupt your sleep. So that's always important. And midodrine is something that we use for when people have a low blood pressure when they go from sitting to standing. That's called orthostatic hypotension. That drug we typically give 3 times a day, but the third dose should be no later than 5 o'clock because if you're lying flat in bed, so say you take it at 7 or 8 and go to bed at 9, that means you're going to have hypertension. It's called supine hypertension. So it's very important to understand when to take your drugs or when not to. Okay. Again, you want all your doctor's name and therapists. You want your medical history. Now, Carol says the date and place. I just like the date and the problem, you know, and if you had a procedure or not. And then when you start a medication, it's good to keep a little diary about the effect. I typically ask people to send me a note or give me a call in a couple weeks to let me know how it's going. So then I can, adjust things as needed. I don't want people to wait until the next doctor's appointment because, as you all know, we don't have much availability. So it's 3 to 6 to 9 months out. And all of a sudden, my screen is frozen. Okay, there. Have an emergency health packet. So this is what you need to have ready if you have an emergency room visit or even when traveling. I think traveling is spelled wrong. You want to keep it in a labeled envelope or a Ziploc bag. I would say have a copy of your medical insurance card and a photo ID. Copy your driver's license. Have your medication list there, your doctor's list, your medical history, your living will or healthcare power of attorney. And if you do have a power of attorney, the general power of attorney is typically for financial issues. So if your son or wife, if they're your power of attorney, that should be in there as well, just in case. All right. So that was all preparation for physician visits. Now let's talk about the hospital. So people with Parkinson's are at a higher risk of hospitalization and face challenges in the hospital. 4 out of every 12 with PD will be hospitalized every year. 3 of the 4 will not get their medicine on time. It's probably 4 of 4. And 2 of the 3 will have complications as a result. So complications would include falls, swallowing changes, muscle deterioration, medication side effects, mental and physical decline, decreased independence. So I was just talking to my brother about this morning. He fell, was admitted to the hospital, and then in rehab. So he had a total of 9 days when he was pretty much mostly in bed. Even in rehab, he had maybe 40 minutes of PT and 40 minutes of OT, and the rest of the time he was in bed. So 100 years ago, when I was in nursing school, we were taught that it takes 3 days to recover from every day you're down. Well, that's a lot, right? You don't just go home from rehab and, resume your normal activities. So that's where you've had some deterioration, both mental and physical. The mental decline is because you're out of your environment, right? So you've been in the hospital, that's a new environment. Now then you go to rehab, that's a new environment. And so it's hard for your brain to adjust, whether you have Parkinson's or not, quite honestly. So you have to allow for more recovery time. And you are going to have a decrease in your independence as a result of that, as I was just chatting with him about this morning. So this is an awesome hospital safety guide that's put out by the Parkinson's Foundation. And I'm going to have the website up there in a minute, but I would encourage everybody to get this. It is an amazing resource. It has tons of information in it, some of which I'm sharing in this, but a lot of it in the beginning, it talks about hospital needs, and every page you go to talks about a different need. So, for instance, need 1, I need my hospital chart to include my exact medications and match my at-home schedule. So it tells you how to hopefully get that done and what the challenges are in that. Medication time is the most challenging thing in a hospital stay. Unfortunately, nurses are not always flexible. I'll just leave it at that. And hospital time, so if the doctor writes 4 times a day, it's going to go according to the hospitals 4 times a day, and that may be 10, 2, 4, and 6, or it could be 6-hour intervals. So 6 a.m., 12, 6 p.m., 12 a.m. So it's very important for whatever physician you're working with to write down the times of your medicine so that the nurses can abide by that. And sometimes what you're on may not be on a hospital formulary, especially if you're on some of the newer medicines like Rytary or Crexont or Droxidopa or Nuplacid. So you may even want to put those bottles in your emergency kit so that you can take them if they let you. Okay. Um, Also, you want to still move when you're in the hospital. You want to move. You have to get up and get out of bed. Now, this is difficult, right? Because maybe you're limited and you have to have somebody with you, and it can't be your partner. That's not going to happen because the nurses want to be the ones to do that. I see something in the chat. Oh, you
Well,
just put the
yeah,
picture.
Maureen, I actually
Okay.
I just put the link
Okay.
to the Parkinson Foundation and this particular hospital safety guide.
Okay, thanks. I got it coming up.
Oh, okay.
Um,
Sorry.
yeah, that's okay. All right. And then, yeah, so let's talk about the forms because these are great. Oh, my computer froze again. Jeez. All right. Now I know these are hard to read, and I tried to make them larger, but I wasn't successful. So anyway, this medication form is included in that book, and there's tear out pages, so you don't even need to recreate it, which is great. So the first page, has your information and then special considerations like you have DBS or you have the Duopa pump or you get dizzy, those kinds of things. And then the second at the bottom and the next page is your medications list. Then there's this summary care for health professionals. This is great. This is what helps the nursing staff and your physician to kind of customize your care. So again, they it talks about preventing medication delays, avoiding contraindicated medications, and those are listed on the second page there. If you see the antipsychotics, the safe ones are listed, and the medications to avoid. Unfortunately, there are still ER physicians that will, if somebody comes in very anxious or maybe borderline psychotic, they will give Haldol. Haldol is a very old drug. It's an antipsychotic, but it blocks dopamine. So then your carbidopa levodopa isn't working. So there's a host of antipsychotics to avoid. What we want to stress are the safe medications, which are Nuplacid or pimavanserin, quetiapine or Seroquel, and clozapine or Clozaril. And I just have to put in just recently, probably in the last 6 months, clozapine. Clozapine, the main side effect, and again, these are the drugs we use for hallucinations or psychotic behaviors, impulse control disorder, compulsiveness, severe anxiety. Okay. Clozapine is usually our third choice. We start with quetiapine, then pimavanserin, then clozapine. Because clozapine, the main side effect, it lowers the white blood count. So you can develop an anemia, aplastic anemia from this. Now, in the past, so for 22 years I'm doing this, if we start somebody on clozapine, they have to have blood work done every week for 6 months, every 2 weeks for the next 6 months, and then once a month. That has been lifted, which is just wonderful for us and for you if you ever need it. But what we as providers have decided is that we would get baseline CBC and CBC and differential before you start it, and then once a month for 3 months. So we're sure that your white blood count is stable and we don't have to worry about that. And but the important thing is that the FDA released the blood work requirement. So now we can use this drug more freely, where before it was just too hard to use because of the blood draws. So that's a huge benefit to all of us. All right. And again, this is a pull out. The pages are perforated and you can just bring these with you to the hospital. Okay, and there's the website, which Chris already put out. I would absolutely encourage everybody to go and either download this or order it, and they will send you a copy for free. It it's the best book ever. So what happens? Why do people get admitted to the hospital? Sometimes we can't solve things over the phone or in the office. If the motor complications are just getting too severe at home, and we can't figure things out. Maybe the care partner has some cognitive issues as well as the person with Parkinson's. Sometimes we just have to admit to the hospital to try to straighten things out. Fall and fractures are probably the most common reason for admission. Pneumonia, cardiac issues, and fainting. Again, the orthostatic hypotension comes in here. There are a limited number of drugs that we can use to deal with those. And so sometimes, again, we have to admit to the hospital to get that under control. Urinary tract infections, GI issues, drug-induced psychosis, again, hallucinations, delusions, paranoia, um, obsessive compulsiveness, impulse control disorders, all of those. And then, of course, just general medical problems. Maybe somebody has heart failure and needs a tune-up, or motor and psychiatric problems. And this list is, non-exhaustive. There's many more reasons. So how do we manage your drugs? Oh my goodness, this is the most important thing. So whoever, probably it starts in the emergency room, right? And that's where the list of your medications or the original bottles you want to bring with you. Now, the thing is, you want to make sure that what you're taking is the same as prescribed on the bottle. And you all know we adjust your carbidopa levodopa whenever we have to, right? So one prescription bottle might say 3 tabs 4 times a day, but really you're taking 3.5. And as a provider, when I ask you, do you want me to change your prescription and send in a new one? And you say, no, I just got a 3-month supply yesterday. Okay, I'm not going to send it. All right. I don't want you to have 5,000 pills. So I will make the change in the chart, but you're not going to get a new prescription. And that's where that discrepancy happens. So I encourage people to write on the bottle whatever we have changed so that you remember that that's what we're doing. It's really important to communicate, especially if you're kind of brittle. And by that, I mean, if you don't get your medication on time, you can go off like that. And it helps the nurses understand Parkinson's if you discuss it with them. Is there a question in the chat? I guess not. Okay.
Yes, there is. I'm sorry, I had to unmute myself.
It's
Uh,
okay.
yeah, Marge has asked if there is an emergency, should they go to UC if they're already a UC neurology patient?
That's the best. That is
Okay,
the best, and I'll cover that in the next couple slides.
okay,
It's important to go. So whatever your problem is, the main problem you're going to the hospital for, go to the hospital where that doctor is in charge. Okay. So if you have a cardiac condition and your cardiologist is at Christ and you're in heart failure, go to Christ. All right. We can talk to physicians on the phone about your Parkinson's if they call us. We can help manage that way. But go where your physician is. So if it's a fall or Parkinson's issues, motor fluctuations, hallucinations, yes, go to the hospital of your neurologist. So for us, that would either be, UC or Westchester. Pneumonia, the two most common causes of death in Parkinson's is pneumonia from aspiration of some food or fluid. So it goes into your lungs instead of down into your stomach, and then you develop pneumonia. Or the other common complication or cause of death is from a fall where you hit your head and you have a bleed. And again, if you have cardiac or vascular issues and you're on an anti thrombolytic, so a blood thinner like Coumadin or Eliquis or dipyramidol, um, Plavix. And the dipyramidol, I'm escaping what the trade name is for that. Again, my brother, he fell about 4 weeks ago the first time, didn't want to go to the hospital. And then the next day, his wife calls and says, he's throwing up. He has a severe headache. I said, get him to the emergency room. He could have a bleed because he's on the blood thinner. Fortunately, he didn't, but that's why we're so cautious with blood thinners. So, anyway, in terms of pneumonia, if you're aspirating, they're going to do a swallowing study. And if you're not swallowing well and it's all going into your lungs, then we have to think about a feeding tube or a gastro tube, a tube that goes right into your stomach. So that will be a way to get nutrition as well as your medication. That's not going to improve your swallowing. It's just giving your swallowing a rest. And then you need aggressive, both pulmonary care to clear out your pneumonia. You also need aggressive speech therapy because you have to strengthen those swallowing muscles. Nobody likes to do speech therapy. Nobody wants to do speech therapy. But if you want to eat again, you have to do speech therapy. And I have seen people be totally dependent on tube feeds or a gastro tube and aggressively do the speech therapy, and the tube comes out and they can eat again. So it is possible to improve those muscles for both speech and swallowing. And you have to do it just like you have to walk to improve your walking. Another possible infection is bed sores or bladder infections. And the bed sores, again, I talked about being mobile when you're in the hospital. Get up and get out of bed, get in a chair. If you can walk with a walker or someone with you, then walk to the bathroom. For men, don't use a urinal. You know, take advantage of the urination to get a little bit of exercise. Bladder infections are probably one of the most common causes of emergency room visits because they can really throw your cognition right out the window. Even a mild UTI can cause hallucinations, delusions, confusion. So again, if you're a longtime patient of mine and you call me with a problem, first thing I'm going to ask, any infection going on? Is he peeing okay? Does it smell different? You need to get a urine check. So the psychiatric issues I've talked about a little bit. Um, Drug-induced psychosis means that the levodopa has contributed to psychosis. Levodopa, amantadine, both of those can cause hallucinations when your brain isn't working well. Sometimes it may be with the carbidopa levodopa that we've increased it a little too much, okay? And we can back down. If you call me and tell me this, like 3 days after I've increased your meds, I'm going to say, okay, take it back down right now. Next dose goes back to the regular dosage. And then we have a talk about risk and benefit, right? So I'm sorry that your walking is not going to improve, but I can't risk hallucinations and what might happen as a result of that. And we do reach a level of side effect and benefit with each drug that we try. I had a call yesterday that this person is having hallucinations, and I believe they're home. And I said, okay, I'm looking at the meds and they're on amantadine for 3 times a day. So first of all, I wanted to start clozapine and I put in the order for the blood work, but that wasn't going to happen till Monday. So I said, okay, let's decrease the amantadine to twice a day. This particular person has significant dyskinesias, so they're probably going to get a little worse, but I might be able to control the hallucinations with just that decrease. So the three drugs I already talked about, quetiapine, pimavanserin, clozapine. So quetiapine, typically we use first line. The other name is Seroquel. We start at a very low dosage. People get very nervous when we talk about antipsychotics, and then they go look up the drug, and then they tell me, I don't want to take that drug because of the side effects. Okay, I get it, but I don't want you to be hallucinating either. And of course, when people hallucinate, they're not really willing to hear that they're hallucinating, right? Because they see what they see. So it's important for the caregiver then to say, I understand you're seeing that, but it's not there. You just have to trust me. It's not there. And kind of think about this. If you're the patient and somebody's telling you it's not there, but you see it, you get a little irritable, right? I mean, what do you mean it's not there? I see it. Okay. So we don't like hallucinations to happen. Um, Sometimes people will say, okay, I see people outside, but I know they're really not there, so it's okay. So if hallucinations are not bothersome and the person retains insight, then we may not elect to treat because of side effects. All right. So quetiapine, the main side effect of quetiapine is sleepiness. And so we give it at bedtime. But some people can fall into such a deep sleep that they may become incontinent during the night. They don't even know that they're incontinent. So it's always, the risk of side effect and benefit. Pimavanserin does not seem to cause many side effects in my experience. Now, I don't know if anybody else has had them. The trade name of that is Nuplacid, and this is the only FDA drug approved for hallucinations in Parkinson's. So why don't we use it first? Well, because it's a newer drug and it's expensive. Okay. Fortunately, at UC, we have a specialty pharmacy, and two pharmacists will work with you. They will check your insurance for coverage. They will see if you qualify for any patient assistance programs if they're open. And then they can give you the exact monthly charge for what this may cost. So say they do all that and they come back and they say, "Hey, it's still going to be 500 a month." And you say, "Well, I can't afford that." Then we have to, troubleshoot. That's when we would probably start clozapine. And now that we don't have the blood draw restrictions, we'll be using that a lot more. So quetiapine is cheap. It's our first line of treatment. Pimavanserin is second, very expensive, and then clozapine. Um, Sometimes people can actually have anxiety as a wearing off phenomenon or as a generalized disorder. Quetiapine can be helpful for anxiety as a generalized disorder. The other two, not so much, but quetiapine can be. And if anxiety is a wearing off, then we have to kind of look at, well, what are your time intervals? If you're on 4 hour dosage intervals and you're wearing off at 3, then maybe we just need to change it to 3 hour intervals. Okay, that means you're going to probably have another dosage a day, right? That dosage, it may flip you into psychosis or dyskinesia. That's where we have to talk to each other a lot or through my chart, okay? So that we know what's going on. Falls and fractures. Um, the chief difficulty with hip fractures is pneumonia and delirium. So we've talked about pneumonia, but delirium is a state of severe anxiety and cognitive impairment. Okay. Um, and sometimes people can have delirium. So if you have a hip fracture, almost always, I don't know the percentage, but almost always, you're going to have surgery with either a fixation or a new hip, depending on the severity of the fracture. So anesthesia is what can contribute to post-op delirium or hallucinations or increased cognitive difficulties. So people will call me frantic that, their person is crazy in the hospital, and that's what's going on. It's from anesthesia and it will clear. If it's very severe, then the hospitalist or the treating physician needs to do something. And if they don't know what to do, then tell them to call us. Okay. So, fall prevention is the most important safety practice to follow. And this means if you need a walker, you need a walker. Okay. I realize there's pride involved. You don't want to be seen out in public with a walker. But if a walker will prevent a fall and an admission to the hospital, you have to accept that. You have to use the walker so that you don't end up with a hip fracture. I can't stress it enough, and I think my brother is finally realizing I'm not giving up on this because now he's using his walker. Oh, it's the most, aging is hard, you guys. Aging is hard without Parkinson's, much less with it. So you really have to be safety conscious and listen to your care partner, your children, your siblings. We all want what's best for you. And honestly, I sat with my brother this morning, and his daughter is here, and said, Chuck, you have to listen to this. And he rolls his eyes at me like, oh dear God, get her out of here. But we have to we have to be safe. And that's the bottom line. Now, you go to the hospital and you're not getting your drugs. All right. There's a very serious syndrome that can happen. It's called neuroleptic malignant syndrome. If you don't have your Parkinson's medication for several days in a row, this can happen and you can die from it. You can have severe rigidity, dysautonomia, and of course, changes in cognition. Now, what's dysautonomia? That means that your autonomic nervous system isn't functioning. What's the autonomic nervous system? That's the nervous system that controls all of the organs in your body. Okay, we have two nervous systems, the central nervous system, which is your brain and spinal cord, and the autonomic nervous system, which innervates your GI tract, your bladder, your blood pressure, temperature, pulse regulator. Okay, so when that shuts down, your body shuts down. Now, if you've been given an atypical psychotic or a drug that blocks dopamine, and there's a list there of those, this can happen. I can tell you from experience. I saw someone in a nursing home who had been doing just great. She had deep brain stimulation, but she had severe off-period anxiety, and she needed her drugs at 3-hour intervals. And so she would go to the nurse's station like 10 minutes before and wait. And then she would get really anxious because they didn't give it to her. And then the nurses started to complain about the anxiety and that she's bugging us all the time. So the doctor at the nursing home put her on Haldol. She comes in the office and she's on a stretcher because she can't move. So it's incredibly important to recognize new drugs and what's going on and the reason for them. And if someone is in a nursing home or rehab, you absolutely have to stay on top of it. And if they're in the nursing home, many of my patients and their spouses or providers will say, you cannot start another drug unless you contact our neurologist. And that does happen frequently. So this is a list of drugs that are dopamine blockers and can lead to muscle stiffness and rigidity. I'm not going to read them all. Quetiapine is on there, but it really shouldn't be. I'm surprised. All right. Some of you may be actually on Abilify or Zyprexa or even Geodin because somebody else has put you on it. This is because our safe antipsychotics weren't helping. So they weren't taking care of your hallucinations. The hallucinations were very scary. They were telling you things to do, and we had to try and get them under better control. So when we do that, when we use one of these dopamine blockers, then we have to carefully monitor that your motor symptoms aren't worse. And we may have to increase carbidopa levodopa at some point. So again, when a physician wants to start you on an antipsychotic, it's incredibly important that they contact your neurologist. The diagnosis of the malignant neuroleptic syndrome is made on a clinical picture. Again, the rigidity, dysautonomia, and changes in mental status, and can be commonly misdiagnosed as sepsis, which is a generalized body infection. So again, medication lists are very important. So you have to immediately withdraw the neuroleptic drugs. So for instance, in the case of that person who came in on a stretcher, I saw that she'd been put on Haldol. I stopped the Haldol. I brought her back in a month and she was up and walking and back to her normal self. They may use bromocriptine or dantrolene in the hospital. Those both help to reduce muscle rigidity. And then when you're back to your baseline, they'll resume the previous doses of levodopa. But they will give you some of that while you are experiencing the syndrome, but at lower doses. Elective hospitalizations. Again, we mentioned this earlier. Go to the hospital where your neurologist is on staff. Find out what the hospital rule is for taking your own medication. Well, most hospitals do not allow it because of Joint Commission, except in the case where it might be a medication that's not on the hospital formulary. And so you use your own and you keep that at the bedside, or they may put it in the nurse's station in your med box. You want to always be aware of any new drug that's prescribed. And again, avoid all neuroleptics and anti-nausea medication except for Zofran. The other name for Zofran is ondansetron. How do we cope with all this? Well, again, you're doing this webinar, so that's good. We want to have education about it. You want to have anticipatory intervention. So call me or call your provider. I'm having a hip replacement coming up. What should I do? If you have deep brain stimulation, do I need to have it turned off for surgery? How should I handle this? If you have surgery that morning, should you take your Cinemet that morning? Typically, I say yes. You take the dose, you take your first dose that morning with a tiny sip of water. It takes 40 to 60 minutes for your stomach to empty. So there's time. The reason why you're told not to eat or drink after midnight in preparation for surgery is in case you would aspirate. Okay. So they don't want a gut full of food if you should sustain a cough or something else, something to cause aspiration. If needed, you can coordinate your surgery with your neurologist. An important thing, when you go in for your pre-op lab work, you might ask to meet with the anesthesiologist so that they're aware of your Parkinson's disease and they can titrate your anesthesia as needed. You want to think about rehab after surgery. I mean, it's clear, like we were talking earlier, if you fracture a femur and you're in the hospital, you're going to have to go to rehab. because it's difficult to manage that at, at home. It needs more time for healing. And you might want to arrange for caregivers in the hospital. So if you're if you have friends, then most friends always say, "What can I do? What can I do?" Well, could you come from 1 to 3, this day? And this is more for help with the spouse or the caregiver. You can't be there 24/7, but see if you can't arrange for friends to come and visit or siblings or whatever. So again, I'm down in Florida with my brother. My his oldest daughter came last Sunday, left Thursday. I came in Thursday. I'm leaving Sunday. His wife comes home Sunday evening. So, we timed our visits to cover the whole time. You want to ask about therapies, physical therapy, respiratory therapy, OT, speech. We talked about that. If you don't sleep, maybe there's the time you could get a consultation with a sleep specialist if it's needed. Again, you want to communicate. You want to take the opportunity to educate everybody that's involved in your care. And when all else fails, send in the dog. Okay, that's that. Questions? Um,
If you have a question, just go ahead and unmute your mic and you can ask Maureen directly.
Maureen, this is
yeah,
Ken. I've
yeah.
got a question. What's the best way in a hospital situation to get the drugs on the schedule that you want them when, as you indicated earlier, the nurses are operating on their own schedule, which could be entirely different? Should you go to the chief nurse or go to the hospital advocate, patient
You need to
advocate?
ask, you need to ask the physician that's in charge of you to write an order for your specific times. If
Okay,
the order is written, so like I said before, if they write QID and your 4 times a day is 10, 2, 6, and 10, QID to the hospital means every 6 hours, 4 times a day. QID is 4 times a day. So every 6 hours, but that's not how you take it, right? So your physician should really write the specific times.
okay.
Good question.
A couple of comments about that hospitalization book from the
Mhm.
Parkinson's Foundation. One is that a lot of people with Parkinson's writing isn't very good, and mine isn't either for that matter. And that can be done on the computer. There's a way to do that, and then everything is very clear. And then the other thing that I've heard recommended is that you put a copy of it on the refrigerator, because that's if you happen to have an emergency where paramedics are coming, that's the first place they're going to look for that kind of information. And we've kind of experienced that a few times, so it does help.
Yeah, good point about the writing. That's where, I would encourage the care partner to write these things down. I missed what you said though, when you said at the beginning, when you said your writing was terrible. What did you suggest?
Well, doing it on the computer,
Oh,
they have
right.
a method where they actually you can do that,
Yeah.
and we've done that with all of ours, and it works really well.
Yeah, another idea is to dictate it into your
Mhm.
cell phone on a message. And you can actually print now from your cell phone if you have a grandchild that helps you with that.
I haven't figured that out yet.
There is software called Dragon that will translate your speaking into writing, but that means you have to buy the software. So, the best bet for that is to ask a friend or to ask a family member to help you with those things. Any other questions?
I've got a comment. I don't know if my mic is on or not. I'm new to this.
It
You're
is,
on,
Mike.
you're on, Michael.
Good. I wanted to put in a plug for Good Sam. Everything I agree with everything Maureen has said. I had to have back surgery about 2.5 years ago for fusion of two discs at the bottom of my spine. And I'd had back surgery in 2020 and it went okay, but I was in the hospital for 6 days and kind of out of it most of the time. So this time I chose Good Sam again because the doctor from Mayfield likes to practice there. I came in on a Friday morning early and I left Sunday evening, held up by bladder issues mostly. It was a wonderful stay. Dr. Lynn, Dr. Espay's fellowship doctor at the time, has sent me a copy of that book, which is fantastic. And I read all these horror stories and I made up a medicine list of my own in great detail. And I took it and all my pills and the list and everything in and said, I need to be able to give these to myself. And I was amazed nobody objected at all. Everybody was friendly and cooperative. I left all the bottles out on my bed tray and they would come in at the specified time and say, did you take your pills? And I said, yep. And then they'd take care of everything else, the blood pressure and thyroid and that stuff. But they were really super and it was a very pleasant stay. I made a copy of my medicine list, took my name off of it. If you would like, I could send it to Maureen. If anybody wants it, you can use it as a model. I based it on the one in the book, but I refined it kind of, and it was my big word processing project. But Good Sam, it was the 6th floor neurosurgery unit. Everybody was super. I said, that's the place to go. I'll spread the word when I can. I was amazed. They were all nice, cooperative, friendly, and I took all my own pills on my own, the Parkinson's pills on my own time.
That's great. That's great to hear. I just want to put a plug in for Dr. Lynn too. So Dr. Lynn was a fellow with us for 2 years and she finished last July and she's employed by TriHealth now. So we do have other movement disorder specialists in the area. So if your insurance, only covers TriHealth doctors, Dr. Iris Lynn is the one to go to.
Maureen, this is Marge. Sorry, I can't I'm on my cell phone in my car. Can't get my picture up. One thing I experienced at UC when my parents were at Westchester UC years ago, they had hospitalist doctors who rotated, and I thought it'd be the same doctor, and it wasn't. So we always had a new hospitalist doctor, and the continuity of care was terrible.
And that's pretty much the trend now, is that you have hospitalists. Your primary care physicians no longer go to hospitals to see patients. And as well at UC and Westchester, the neurologists rotate every week. So you will have a different neurologist but when you're at those hospitals, they always contact me or the physician provider to kind of run things by us.
Well, that's good to know. Thank you.
Mm-hmm.
Hi, Maureen. This is Ann Hockwalt. Bill and I are here joining you today. I have a question. You had a long and very helpful list of meds that have unfavorable interactions with people on Parkinson's medications. Is that a list that we should include in our packets if we have a hospital visit to say to the doctors, please don't give any of these unless you talk to my neurologist first?
Absolutely.
Okay. Would it be
and what?
I was just gonna say, would it be possible for us to get that list written down, or maybe your slides shared, so that I make sure I get the spelling correct?
Yeah, this Zoom will be online at the ParkinsonCincinnati.org website in a couple weeks. Yeah.
Okay, perfect.
Yeah, and again, that list is most of it's from that book. The real main offender, typically in a hospital stay, if there's no cognitive issues, no urinary issues in terms of UTI that's affecting things, the main drug that people use for post-op nausea is typically Phenergan. And Phenergan, the other name is promethazine. That's the one that is a dopamine blocker. And that's why we recommend Zofran.
Gotcha.
When
Okay.
anybody calls me, I'm going to have surgery, that's the first thing I say. Make sure you don't get Phenergan. You need Zofran. But honestly, the anesthesia drugs have improved so much that I don't hear a lot of post-op nausea anymore, which is great. Nothing worse than nausea.
It takes, if you take the Zofran before surgery, it usually, because I've always had problems with that too. And if you take the Zofran before you go into surgery, it usually cuts down, the fact that you might get it again. Or get it, they give it, you have to, sometimes it's better to be proactive about something like that.
And that's why I encourage people to ask to meet with the anesthesiologist as well. So that, and Medicare will cover that. You don't have to worry about it's not covered. It is.
Makes a difference.
Anything else? Okay, this was great. Thanks so much for showing up.
Thank you.
Thank you.
And have a great
Thanks,
day.
Maureen. Good luck with your brother.
Thanks.
Thank
I'm
you.
out of here tomorrow.
Yes. Thank you, Maureen. It was super.
You're welcome.
Thank
Thanks,
you.
Have a safe trip.
All right. Bye, everybody.
Bye-bye.
Bye.
Take care.
Thanks,
Bye-bye.
everyone. And reminder that in about a week, we'll have this presentation up on our website, parkinsoncincinnati.org, under the Learning tab.
And hey, don't forget, Steady Strides is coming up. So take a look at the website for that too.
And for baskets too.
And for baskets. If any
Donate
of
a
you,
basket or gift cards or any of your specialties.
yeah,
Thank
that
you.
would be great. We need
Yeah,
help.
super.
All right. Bye,
Thanks,
guys.
everyone.
Have a
Bye
good
now.
weekend.
Bye-bye.
Bye-bye.